protein dependent receptor. It has got reduced duration of intracellular activity, and hence there is lesser hypercalcemic response, and even there is lesser suppression of the bone, there is lesser stimulation of the bone resorption. So normally what teriparatide does, it improves the bone formation, it also enhances or also increases the bone resorption. On the other hand, abaloparatide, because of its shorter duration of action, it only improves the bone formation, and it does not enhances that much level of the bone resorption which is seen with the teriparatide. So this injection has to be given intermittently for around 18 months, and it has shown that it stimulates the osteoblast and bone formation. So it is a daily, again, self-administered subcutaneous injection. The dose is 80 micrograms per day, and it leads to significant improvement in the vertebral spinal BMP. It has shown reduction in the vertebral fracture in comparison to the teriparatide. But importantly, it also shows greater non-vertebral fracture reduction, which is not there seen with the teriparatide. The safety profile is similar to teriparatide, in fact, lesser risk of hypocalcemia, and it is an FDA-approved agent for use in osteoporosis in postmenopausal women. And some steam patch versions are also available for short-term use. Now, again, this is a very important slide which compares the anabolic window of all these anabolic agents. As I was discussing, all these anabolic agents, how do they act? They increases the bone formation, but both abaloparatide and teriparatide, they also increases the bone resorption. But still there is a difference among this molecule. As you can see here, the teriparatide, the anabolic window is less compared to abaloparatide and romosozumab. So what are we looking at? What is this anabolic window? It is a time period where there is increase in the bone formation marker and there is less in the bone resorption. So lesser will be the increase in the bone resorption marker, more will be the anabolic window. So in the teriparatide, we can see that the bone formation marker along there is increase in the bone resorption marker simultaneously. So the anabolic window time period is less. However, in the abaloparatide, this bone resorption marker, the increase is less compared to the teriparatide. And in the romosozumab, as I already showed, with that P1NP graph, there is a rapid increase in the bone formation marker, and there is a suppression in the bone resorption marker. That is, the CTX levels was low with the romosozumab. So here again we get a 1 year full anabolic window. Now this is a summary of all the osteoanabolic agents which I was discussing. As you can see here, these all are available in the injectable form. There is with teriparatide, there is increase in the bone formation as well as increase in the bone resorption. Abaloparatide, same increase, but with the romosozumab, there is only increase in the bone formation and there is a decrease in the bone resorption. So this is very important. And this is the graph which compares the mean increment in the BMP with this 3 different agents. As you can see here, the mean increment in the BMP is highest with the romosozumab to the point of around 13 to 14% at the level of spine. At the level of hip, it is around 6 to 7%. While with teriparatide and abaloparatide, at the spine, the increment is almost same at around 8 to 10%. At the level of hip, it is around 3 to 4%. Now the next group of agent is the anti-resorptive therapy. So these are the target areas where we can target the anti-resorptive agents, which includes the rank ligand and this lysosomal enzyme, that is the cathepsin enzyme, and the third is the SRC kinase enzyme. So first start with the cathepsin key. So what are these cathepsins? Cathepsins are the group of lysosomal enzymes. They there are n number of cathepsin enzymes starting from A to Z. So these enzymes differ from each other in the form of their structure, their catalytic mechanism, and the kind of proteins they cleave. So here we are focusing to the cathepsin K, which belongs to this cysteine group of cathepsin enzyme. So how do they act in the very highly acidic medium in the osteoclast? There is increase in the secretion of cathepsins K by the lysosomes, and what do? They causes degradation of the collagen. So if we inhibit this cathepsin K activity, then we can inhibit the bone resorption. So what are the conditions which are associated with cathepsin K deficiency? It's pycnodystosis, which is characterized by short stature, increase in the bone mass with fragility, Even in the mice, it has shown that it leads to osteoporosis, increased bone formation, and on the other hand, if there is overexpression of the cathepsin K, then it means that there is increased osteoclastogenesis, high bone turnover, further leading to osteopenia. So these are the what the usual anti-resorptive does till date. So these bisphosphonate, they inhibits both the osteoclast viability as well as they are anti-resorptives, while the cathepsin K inhibitor, they are only anti-resorptives that do not affect the osteoclast viability. So this is the difference between the usual or the classic anti-resorptives and the cathepsin K inhibitors. So there are three cathepsin K inhibitors. One is the odanacatic, which is given 50 mg weekly, and the other two are in the developmental phase. So today we will focus only on odanacatic. That too again not FDA approved. It is highly selective, non-basic inhibitor of cathepsin K. It is the most potent inhibitor of cathepsin K. The oral viability is higher than oral bisphosphonate. It is metabolized by cytochrome P450 enzyme and it do interact with other medications. Hence, some studies have shown that it leads to increased risk of CV events and hence it has not been FDA approved. So we need more cathepsin K inhibitor molecules which can provide better anti-resorptive therapy. In the phase 1 study, it has shown that dose-dependent suppression of CTX. The OCEAN study, which is a phase 2 study with this drug, shows that there is an increase in the spinal BMD by 5%, total hit by 4% compared to the placebo. In the LOF study, which is a phase 3 study, it was stopped early because of the robust efficacy of the drug. There is a transient reduction of the bone formation marker also, and the adverse events like scleroderma-like lesions were seen, which were compared to the placebo arm. So this is how there is an improvement in the BMD with the use of this drug by around 2 to 3%. And again, it's a similar representation. Odanacatic is increasing the spinal BMD over 2 years by around 5 to 6%, and with the other drug, that is ONO, there is again 5 to 6% improving the spinal BMD. So cathepsin K inhibitors have got similar reduction in bone resorption markers with bisphosphonates. There is a lesser reduction in the bone formation marker than with bisphosphonates. And they have got rapid onset of action after stopping therapy, unlike bisphosphonates where we need a drug holiday and the drug keeps on acting for around 5 to 6 years even after stopping the drug. And no serious adverse events have been seen with odanacatic and ONO 534. Apart, few studies have shown that it leads to cardiovascular events. Now, another anti-resorptive agents which we are using is denosumab. It is again a fully human monoclonal antibody of IgG2 isotype. It is highly specific to the human rank ligand. It has got high affinity to rank, and giving this drug doesn't lead to formation of any neutralizing antibodies in the clinical trials. It has got T-half of 34 days and the recommended dose is 60 mg, which is given every 6 months subcutaneously. So how does it act? So in a normal physiological state, there is a balance is required with the rank ligand and the OPG ratio. So if any alteration happens in this ratio, then it can lead to increase in osteoporosis. So in conditions like postmenopausal women where there is estrogen deficiency, there is increase in the formation of rank ligand, and we know that rank ligand leads to osteoclast formation. It promotes bone resorption. So if we bind this or if we inhibit this rank ligand binding to its rank receptor, then probably we can inhibit the bone resorption. So this is the way it acts. Denosumab, it inhibits the rank ligand and hence it inhibits osteoclast formation and its function and survival. So denosumab again, it is an anti-resorptive agent and it also affects the osteoclast viability unlike the cathepsin K inhibitors. This I have already discussed. Again, denosumab has to be given along with calcium and vitamin D. It doesn't lead to any GI side effects like bisphosphonates. It can be safely given in patients with severe renal dysfunction even with EGFR less than 30. On the other hand, bisphosphonates have got contraindication to be used with EGFR less than 30. So this is the area where denosumab has got an advantage over the bisphosphonate. Certain contraindications, it cannot be given with the patients who have got known etiology behind hypocalcemia like hypoparathyroidism, small bowel resection. It cannot cannot be used in pregnant and lactating women or in patients who have known to have hypersensitivity to dulcinea. So this is the evolving landscape of the management of the osteoporosis. In the year 2003, there was teriparatide, and now we have moved on. We discussed the denosumab, pranisumab, and the latest one is the osteoporosis therapy. So basically, it is not a drug; it is a vibration therapy, where we give a high frequency, low magnitude vibration. It is shown to stimulate the bone formation, reduce the bone resorption, and even improves the blood circulation. So it is the latest one, 2024. It does not have any FDA box warning. The efficacy is less; it is only 5 to 10%. So probably the combination of all those therapies we should use in our practice to have a complete osteoporotic management. So to conclude, combination of new drugs will improve the efficacy and adherence, but at a higher cost. Osteoanabolic agents have got quicker action and they are more effective in improving the bone mass compared to the oral bisphosphonates. But do remember, osteoanabolic drugs have to be stopped after 1 or 2 years of therapy, because later on that anabolic window periods vanishes and then they have to be followed by anti-resorptive therapy. In cases of severe osteoporosis with multiple fractures with T-score of less than -3, and so in those group of patients, we can even start with a combination therapy of both anti-resorptive as well as osteoanabolic therapies. Now this cathepsin K inhibitors, they are a newer class of agents, so we need more research, we need more drugs in this area. So to end, don't wait for the fracture, act before the crash. Thank you.